Morning, ma'am.
Yeah, now it is live streamed. Fine. So, good evening, all. Welcome you all for the IPNA Endorsed Webmaster Series 2025. This is our annual fifth webinar series. And this series, we are going to cover on Pediatric Nephrology Symposium, which is basically based on chronic kidney disease. And it's spanning from April 9th to May 3rd, every Wednesday and Saturday. And this is our webinar too. And this session, we are starting our polling sessions for the trainees. And the highlights of our session are all practical aspects of pediatric CKD will be delivered by experts. As you see here, our speakers are really experts in CKD. And the polling session for the trainees with cash rewards will be offered. And the first and second place and third winners will be given the cash reward of 5,000 and 2,500 INR respectively. And instruction of the polling session will be given just prior to the session. And the polling session will be taken up after the Q&A session. Now I request Dr. Amrish to introduce our moderator, Dr. Zubeda Rumana.
Thank you, Dr. Ganeshan, and welcome everybody to the second webinar. The first webinar was an overview of chronic kidney disease, and it was very well attended, and we had a lot of international audience. So please keep on showing your support. And we thank International Peds Nephrology Association for their support and funding. And we also appreciate the support of the Sister Renal Center program between Dr. Ganeshan and myself at Children's Hospital of Michigan, USA. So we hope to bring more scientific sessions like this for you. And to run today's scientific session, I have internationally known Dr. Zubaida Romana, and she is a consultant in Asghar Ali Hospital, and she's a pediatrician and a pediatric nephrologist in Dhaka, Bangladesh. So welcome, Dr. Romana. We are very excited to have you here today. Her academic interests are renal critical care and voiding dysfunction, and she's an accomplished pediatrician and pediatric nephrologist with she being the scientific secretary in the Pediatric Nephrology Society of Bangladesh. She has had other posts that she has participated in, and she has been the ex-cultural and social welfare secretary, and she has been the ex-associate editor of the Pediatric Nephrology Journal of Bangladesh. She has had multiple publications in different national and international journals, and she has presented oral posters in national and international scientific conference. We are really excited to have you, Dr. Romana, today, and we would want you to introduce the two wonderful speakers that we have today. Thank you. Over to you, Dr. Romana.
Thank you, sir. Dr. Amrish, it's a very nice introduction of myself. I'm welcoming all of you to today's webinar, and I just thank Dr. Kalaivani and Dr. Amrish for inviting me. It's really a pleasure and great honor for me to be here with all of you. And I congratulate Dr. Kalaivani for his incredible job, and she is doing this webinar year after year, and she's trying to cover all the topics of pediatric nephrology in this webinar series. So this time we are talking about chronic kidney disease, and today we will discuss on two important topics, and learned speakers are with us. And our first speaker is Dr. Sriram Krishnamurthy. So he is currently the professor in the Department of Pediatrics in Jawaharlal Institute of Postgraduate Medical Education and Research from Pondicherry. His academic interest is glomerular disorder, tubular disorder, and AKI. He has multiple publications, and it's already covered the whole slide. So, and big congratulations for you all these research articles. So I'm not wasting much time. So over to you, Dr. Sriram. The mic is on all of you, all for you.
Thank you, Dr. Zubeda. Are the slides being seen?
Yeah, it's fine.
Okay. Good evening. I'll be speaking on the etiopathogenesis and the mechanisms of chronic kidney disease in children. So the specific learning objectives of this talk are to study the etiopathogenesis and mechanisms of chronic kidney disease in children, to see the etiological approach to a child with chronic kidney disease, and with the help of case scenarios, we will try to illustrate the etiology and early diagnosis of chronic kidney disease. So we know that CKD is defined by the KDIGO as abnormalities of kidney structure or function, which are present for more than 3 months with implications for health. So these uh, kidney structure and function abnormalities encompass not only biochemical abnormalities, but also structural abnormalities, abnormalities detected by histopathology, proteinuria, urine sediment abnormalities, or a history of kidney transplantation as well. The classification of chronic kidney disease, we know that the KDIGO classifies based on the GFR categories and based on the albuminuria categories. So based on the GFR categories, we classify into G1, G2, G3A, G3B, G4, and G5 with EGFR of more than 90, 60 to 89, 45 to 59, 30 to 44, 15 to 29, and less than 15 ml per minute per 1.73 meters square respectively. Whereas the albuminuria categories are subdivided into A1, A2, and A3 based on 30 milligram per gram, 30 to 300 milligram per gram, and more than 300 milligram per gram of albumin creatinine ratio respectively. So the epidemiology wise, when you see across all registries in the world, CACUT, that is congenital anomalies of kidney and urinary tract, make up most of the causes of chronic kidney disease across the world, whether it is developed countries or whether it is developing countries. What are the early detection of CKD challenges? So these challenges include multiple. These would be the asymptomatic nature of many kidney abnormalities, the non-specific symptoms of kidney disease, for example, anemia, poor growth, short stature, rickets, or vomiting, which mimic many other organ systems, leading to referral to various kinds of people, including hematologists, orthopedicians, etc., which I will be illustrating through some cases that I will be presenting sometime later. Missing a past history of urinary tract infections or abnormal antenatal ultrasound findings, missing a family history of young onset chronic kidney disease, which actually points towards an underlying genetic or metabolic disorder, and of course, missing recording the blood pressure because of technical problems, and wrong interpretation of serum creatinine. That is, for example, an infant has 0.8 and you take it as normal. So you don't measure the EGFR. These are some challenges in early detection of CKD. In addition, lack of awareness because of certain things like nocturia or secondary nocturnal enuresis being interpreted as normal, whereas they are not normal in children. In addition, there may be some clues in the blood or urine labs which may be confounded by certain illnesses. So the etiologies of chronic kidney disease in children include congenital anomalies of kidney and urinary tract, including posturethral valves, vesicourethral reflux, hypoplastic, dysplastic kidneys, etc. Various kinds of chronic glomerular disorders, including steroid resistant nephrotic syndrome, especially FSGS, rapidly progressive glomerulonephritis, IgA nephropathy, IgA vasculitis, lupus nephritis, or various forms of C3 glomerulopathies, including dense deposit disease and C3 glomerulonephritis, cystic kidney diseases, including ARPKD, ADPKD, nephronophthisis, tubular disorders such as Bartter syndrome, Dent disease, distal renal tubular acidosis, Fanconi syndrome, cystinosis, etc., atypical HUS, inborn errors of metabolism, including primary hyperoxaluria, Fabry disease, which is alpha galactosidase deficiency, cystinuria, xanthinuria, methylmalonic acidemia, inherited glomerular disorders such as Alport syndrome, diffuse mesangial sclerosis due to various kinds of mutations such as WT1, LAMP2, PLCE1 mutations, etc. Kidney stone disease, chronic tubulointerstitial nephritis, various forms of vasculitis such as Takayasu arthritis, polyarthritis nodosa, ANCA vasculitis, etc., and snakebite as well. So, what are the mechanisms of chronic kidney disease? Let us see some insight derived from risk factors. So, these may be divided into non-modifiable risk factors for chronic kidney disease and modifiable risk factors for kidney disease. So, the non-modifiable risk factors include low birth weight, prematurity, somatic growth with decreased renal mass, previous acute kidney injury, or a low GFR. Whereas the potentially modifiable risk factors are many, but the two most important ones are hypertension and proteinuria. So this is what we target in most of the CKDs, managing the hypertension and managing the proteinuria. These are the two most important ones that help in retarding the progression to end-stage kidney disease. Of course, there are many others like metabolic acidosis correction, anemia correction, hyperphosphatemia management, etc., that will help in management. But most important ones would be hypertension and proteinuria that I mentioned. So some other contributing factors like elevated uric acid, metabolic syndrome, glomerular hyperfiltration, etc., are described, but their role is like still under investigation in many cases. So which are the conditions which predispose to chronic kidney disease? What are the risk factors? These include prematurity and low birth weight. The reason being that these babies have a lower nephron endowment because nephrogenesis stops at around 36 weeks. So if there is a lower nephron endowment, it leads to a lower nephron number. That leads to increased glomerular injury and increased glomerular hyperfiltration, which results in glomerular hypertrophy and a sort of maladaptation. Single kidney, for the same reason, it could be congenital or after a nephrectomy, can produce a maladaptation. AKI survivors are predisposed to CKD. Chronic illnesses like chronic liver disease, diabetes, cardiac disease, or rheumatological illnesses like lupus, malignancies, NSAID intake or native medication, lack of prompt treatment in rapidly progressive glomerulonephritis that leads to the cellular crescents transforming into fibrocellular or fibrous crescents, a family history of young onset chronic kidney disease. So the various markers of kidney disease progression include hypertension, proteinuria, and a fall in the estimated glomerular filtration rate. This table summarizes the correlation of the clinical and the pathogenetic stages in the progression of FSGS from an initially injury phase to an end-stage kidney disease. So when there is a genetic predisposition, it leads to an initial lesion, and these initial lesions, they may progress to a chronic FSGS leading to progression to the CKD. Whereas when you see the pathogenetic stages, they include an injury stage with a consequent response, a repair or a scar formation stage, and then a maladaptation phase. The corresponding clinical disease phases of these three pathogenic phases are initiation, consolidation, and progression. So the term injury here, which is the first pathogenic stage, is applied broadly to include any circumstance that may cause disordered structure or function. And these injuries may be congenital, for example, hypodysplasia, or it may be genetic in origin, for example, podocyte mutation, cystic kidney disease, or tubular dysfunction, metabolic causes like diabetes, toxic or environmental causes like calcineurin inhibitors or toxic nephropathies, or as a result of systemic lupus or hypertension or any other systemic illness. So as the chronicity increases, the pathogenetic mechanisms become increasingly similar to those in other diseases. So the initial phases are more specific, but later on what we see are quite common in clinical practice. This diagram summarizes the pathogenetic model of chronic kidney disease. You have an injury, as I mentioned before, that leads to an initial response. This leads to a repair process. If the repair process is insufficient or excessive, it results in a decreased renal functional mass that leads to malabsorption, abnormal physiology, and chronic kidney disease, which is characterized by progression of the chronic kidney disease. However, when the repair process has been successfully completed and terminated, or if there is an adaptation, then it results in a new steady state leading to improved health. So that situation will not be characterized by chronic kidney disease. This is the CRIS theory, which is actually describing a misdirected filtration to be important in the pathogenesis of chronic kidney disease. So in the first phase, what happens is with the loss of podocytes, glomerular synechia form. So these are characterized by adhesions of the denuded glomerular capillary tuft to form these glomerular capillary tufts. They adhere to the Bowman's capsule. The second phase is characterized by plasma proteins extruding directly into the tubulointerstitial compartment. This results in an inflammatory process being established that leads to scarring the tubulointerstitium and consequently obstructing the glomerular outflow. So this explains why in many glomerular diseases, tubulointerstitial damage also occurs as well, because the plasma proteins are extruded directly into the tubulointerstitium because of the glomerular synechia. So what we have seen till now is that when we have a podocyte injury or a mesangial cell injury or an endothelial injury or a tubular cell injury, you ultimately start getting a proteinuria. The proteinuria leads to tubular cell activation, and this invites the myofibroblasts. So the myofibroblasts are either resting myofibroblasts in the kidney, or they may be derived from some bone marrow precursors. And these myofibroblasts, what they do is they lead to tubulointerstitial fibrosis and loss of the nephron mass. And similarly, the tubulointerstitial fibrosis leads to a glomerular tubular disconnection and loss of the nephron. In addition, the tubular cell injury invites a tubular cell activation, a tubular cell apoptosis, an inflammatory response, and ultimately a tissue hypoxia. So irrespective of whether you have a podocyte injury, mesangial cell injury, or an endothelial cell injury, or tubular cell injury, the ultimate result is a myofibroblast induced tubulointerstitial fibrosis and loss of the nephron. So there are various pro-inflammatory or pro-fibrotic markers, including TNF alpha, TGF beta, IL-1 beta, or complement proteins. These are all pro-inflammatory or pro-fibrotic in nature. These also include the connective tissue growth factor, platelet-derived growth factor, etc. And similarly, reparative or in anti-inflammatory or anti-fibrotic or antioxidant substances. These include the CSF1, IL-10, IL-22, heme oxygenase, BMP7, epidermal growth factor, and many other things. So these are secreted from a whole lot of various cells, including the renal epithelial cells, macrophages, T cells, tubular cells, renal endothelium, macrophages, NK cells, Th2 cells, endothelial cells, etc. So this flow chart illustrates the biological processes that contribute to scarring in chronic kidney disease. First, as I mentioned, there is an injury phase, which can be due to a genetic disorder or inflammatory or toxic or physiological stress. This results in an immune response, initial response characterized by inflammation, protease production, apoptosis, necrosis, cytokine production, oxidant stress, capillary leak. This triggers a repair process. The repair process is characterized by increased extracellular collagen matrix synthesis or remodeling, and that leads to angiogenesis, cell proliferation. So when this process is insufficient, it results in a uh, adaptation and an abnormal physiology, and that leads to a chronic kidney disease. Similarly, when it is excessive also, it results in a new steady state. When it's excessive, then also it results in an abnormal physiology and a chronic disease. Whereas when there is a new steady state, it can result in proper health. So we can also see that in renal development, mesenchymal cells condense around the ureteric bud and they differentiate into the epithelial cells. This is called the process of mesenchymal to epithelial cell transition, the MET. These cells become cuboidal and rest on a tubular basement membrane with tight cell-cell junctions that permit high transport activity and capacity. If these cells are activated by an insult, for example, proteinuria, they de-differentiate. So this results from MET to EMT, that is epithelial to mesenchymal transition. And these de-differentiated cells then produce a process of cytokinesis, protease production, and ECM production. And then we have a vicious cycle of nephron loss and its risk factors. So the injury leads to inflammation, apoptosis, EMT, and fibrosis. This leads to ultimately a loss of nephrons. There is an increase in the single nephron glomerular filtration rate. This results in increased delivery of proteins or filtrate to the tubules, remnant nephron hypertrophy, hypoxia, ischemia, and this produces an increase in the per nephron energy requirement, anaerobic metabolism, generation of reactive oxygen species, and this sets up a vicious cycle of nephron loss and its risk factors. So what is the relationship between the glomerular, tubular, and the interstitial events in chronic kidney disease? When there is a glomerular injury, you get a podocyte depletion, glomerular loss, nephron overload. This increases the metabolic demands in the tubules, and there is an ischemia and hypoxia leading to tubular cell activation. Similarly, when there is a tubular injury because of genetic tubular toxins or metabolic or ischemic or infectious causes, ultimately there is decreased tubular cell delivery with a whole loss of cytokines, as I mentioned before, lipids, complement, reactive oxygen species, and these ultimately prove that even in a glomerular disease, there is significant tubular compartment, there's a significant tubular interstitial component to the progression. So let us see the normal and the abnormal extracellular matrix components in the kidney and the factors that regulate the extracellular matrix protein expression. So normally in the basement membrane, we have laminin 5 and we have collagen alpha 3, alpha 4 and alpha 5 of the collagen 4. When ultimately myofibroblasts come, various scar components such as fibronectin, basement membrane collagens, which are sheet-like, and interstitial fibrillar collagens, they take over. And there are many regulatory factors in this process, including TGF-beta. So we will see that enalapril and many other renoprotective strategies, what they do is they also bring down the TGF-beta levels, and so they are renoprotective. And we summarize by the pathophysiology by mentioning that there are two waves theory of cytokine mediated and repair in glomerular disease. The first wave is characterized by an injury and response, which is characterized by cytokines, altered cell to cell or cell ECM interaction, leading to proteinuria. The second phase is characterized by repair, which is characterized by cytokines. This phase, you also get a mesangial cell activation, increased ECM expression, and deteriorating microenvironment with cell dysfunction. This ultimately results in a maladaptation that is characterized by apoptosis, proliferation, and fibrosis in the kidney. And this phase then transforms it from reversible to an irreversible phase. What is the role of angiotensin in the scarring process? So angiotensin 2 normally binds to the AT1R receptors, and ultimately you get many chemokines, cytokines, and growth factors increasing, and this promotes fibrogenesis, ECM accumulation, and proteinuria. There is cell proliferation as well. Similarly, angiotensin 2 is also pro-inflammatory, and it results in chemotaxis with a whole lot of chemokines getting stimulated, and these cause activation and recruitment of the inflammatory cells, and ultimately they also result in a pro-inflammatory state, ultimately resulting in renal fibrosis. What are the benefits of AC inhibitors and ARBs? To understand this, we need to know the classical uh, renin-angiotensin-aldosterone pathway, and there is an alternative renin-angiotensin-aldosterone pathway as well. The classical pathway is initially from the first substance in this pathway is the angiotensinogen, which is produced by the liver. The renin from the kidney stimulates it, converting into angiotensin 1. And then the ACE from the lung stimulates into angiotensin 2. Angiotensin 2 acts on the angiotensin 1 receptors, leading to vasoconstriction, inducing a cell proliferation, fibrogenesis, hypertension, and pro-inflammatory state. And we also have a alternate RAS pathway in which ACE2 is there. This enzyme converts these vasoconstrictive substances, these pro-inflammatory substances, into the more benign angiotensin 1 to 9 and angiotensin 1 to 7. These substances are more renal friendly, and they cause a vasodilation, anti-proliferation, anti-fibrosis, and anti-hypertension in the body. So our body is characterized by a balance between the classical RAS and the alternative RAS. So when there is an imbalance in this in favor of the classical RAS overstimulation, you start getting renal fibrosis. So let us see where the ACE works. So the ACE inhibitors, they work in converting, they block the angiotensin 1 to angiotensin 2 conversion. And so angiotensin 2 is not able to act on the AT1 receptors, and therefore this offers a renoprotection. Similarly, the ARBs, what they do is they prevent the conversion of angiotensin 2 binding to the AT1 receptors, and so they will also help in renoprotection effect. This graph summarizes the changes in GFR and calcium phosphorus hemostasis in the pathogenesis of uremia. So when the mineral levels, that is calcium and phosphorus, exceed the normal functional capacity of the remaining tubules, serum phosphorus rises, and this stimulates FGF23 increase in the body, and that is going to lead to further renal damage. We find that phosphaturic hormones increase in response to serum phosphorus increase. They are normally meant with an intention to normalize the calcium and phosphorus levels, but when the FGF23 levels rise a lot, what happens is that there is a cardiovascular damage, and this potentiates the renal progression from an initial stage of CKD to a end-stage kidney disease. So with this, I start with a few cases to illustrate the pathology of chronic kidney disease. We have case 1, which is an 8-year-old boy who presented with deformities of the limbs, and this child was found to be short stature. Outside, he was managed, and he was thought of as rickets, and he was found to have a high phosphorus at another institute. The alkaline phosphatase was also extremely high. This was the status of his limbs. You can see the severe bony deformities. He was treated there with mega doses of vitamin D, followed by corrective osteotomy, and later brought to our hospital for short stature evaluation. We observed that the younger sibling, who was 6 years old, was actually taller than him. And we also observed, while taking a history, that there was polyuria, nocturia for 4 years with secondary nocturnal enuresis. The child had been born to second-degree consanguineous parents, and a whole lot of all this information had been missing in the hospital from where the child had been referred. Of course, he had some non-specific symptoms like poor appetite as well. So the phosphorus was very high in this case, and that is an atypical feature for a nutritional rickets. So what we found was his urea and creatinine were extremely deranged. The paroth hormone was also extremely high, and he was having high anion gap metabolic acidosis with vitamin D levels being normal because of all those vitamin D therapies that he got outside. On ultrasound, he was found to have small kidneys with corticomedullary differentiation being poor, but there were cysts noted at the corticomedullary junction in both the kidneys. The bladder was normal. There was no ureteral dilatation. There was no hydronephrosis. So we thought of nephronophthisis as a possibility, and the child underwent a next generation sequencing, which confirmed nephronophthisis type 1. This child was started on medical therapy for chronic kidney disease and later initiated on maintenance hemodialysis. So this is one of the examples where a late diagnosis of chronic kidney disease was there because of a lack of awareness and because of a late referral to us. We picked up CKD on time, but this is often a scenario where children with bony deformities are referred to other specialities and they don't arrive to us on time. The second case is a 1.5-year-old girl presented with progressive pallor for 7 months with poor growth. She had been again evaluated elsewhere, was found to have a hepatomegaly with a splenomegaly as well. There was a low hemoglobin and low platelet counts. The creatinine was 0.81 in a 1.5-year-old girl. This was actually thought to be normal at another hospital, and she was evaluated for the cause of anemia by a hematologist, transfuted, transfused packed red blood cells, and done investigations on the lines of a hematological disorder, including bone marrow examination and HPLC for hemoglobinopathies, which were not found to be remarkable. They left against medical advice from that hospital and then referred to us. And we found that the child was having stage 2 hypertension with echo and fundus being normal. We found that the child had nephromegaly bilateral as palpable kidneys and splenomegaly and hepatomegaly as well. The ultrasound showed huge nephromegaly and with increased echogenicity. There was a history of a previous child with CKD in this family who had died, and this history also had not been taken. In the previous hospital, you would notice that the blood pressure also has not been taken. So all these findings had led to a late diagnosis, and this child was born to third-degree consanguineous parents. We evaluated further and found bilateral enlarged kidneys, and the MRI also showed evidence of Caroli disease and congenital hepatic fibrosis. So in this scenario, we considered a possibility of ARPKD with Caroli disease and congenital hepatic fibrosis, and the diagnosis was confirmed by a next generation sequencing showing homozygous missense mutation in the PKHD1 gene. The child underwent an endoscopy which showed esophageal varices grade 3, and the EGFR was found to be 49. She was started on enalapril as she was in CKD 3A, and later required multiple antihypertensives on which blood pressure control is done well, and medical management of CKD was also done. The third case is a 5-year-old girl presented with severe headache and vomiting, and the blood pressure was found to be very high, stage 2 hypertension. And this child was found to be having no edema, anemia, headache, or vomiting. There was a past history of recurrent fever with focus, which used to resolve with antibiotics. Urine culture had never been done, and she was always prescribed antibiotics empirically. She was found to have one kidney being hypertrophied and the second kidney being small. The creatinine was normal. The urinalysis showed no pus cells, and echocardiogram showed normal echocardiogram, but the fundus showed a grade 2 hypertensive retinopathy. So this child further underwent a DMSA scan and was found to have a small right kidney with only 18% differential function, with a defect in the left upper pole medially. And then she underwent an MCU, which was found to have a right grade 5 and a left grade 3 VUR. And so this is actually a case of reflux nephropathy. The child was on cotrimoxazole prophylaxis and was given management for CKD and hypertension. So I've shown you 3 cases so far. The first being a case of nephronoptosis, the second being a case of ARPKD, and the third being reflux nephropathy. So now we proceed to a case 4, a 9-year-old boy with red-colored urine for a week, no fever, burning micturition, rash or edema, no drug intake. Family history of CKD3A in the mother was there, and the cause for that was unknown, and she was branded as a CKD-U. The child's blood pressure was normal. There was no edema pallor, but the urine shows plenty of red blood cells which are dysmorphic. The creatinine was 0.81 with an EGFR of 64, and the C3 was normal. Serum albumin was normal as well, with the hemoglobin and platelets being normal. Her previous records 2 years ago also indicated a hematuria with no proteinuria. So we initially thought, what could be the causes of recurrent hematuria? Could it be IgA nephropathy, Alport syndrome, hypercalciuria, thin basement membrane nephropathy? So we started evaluating. We did a pure tone audiometry. This showed a mild sensorineural hearing loss in the right ear and moderate sensorineural hearing loss in the left ear. The eye examination showed no lenticonus, cataract, or macular lesions. In view of the sensorineural hearing loss and CKD with microscopic hematuria and a family history of CKD in the mother, we evaluated her by next generation sequencing and found it to be an X-linked Alport. And management of CKD done was in this case. And our adult nephrologist colleagues were informed that the parent is not actually a CKD-U, she is actually a Alport, most likely. And that was confirmed by a next generation sequencing in the mother as well. Our case 5 is an 8-month-old girl, non-consanguineous parent, second born, poor weight gain with recurrent dehydration. The birth weight was 2.46, and now she was only 4.2 at the age of 8 months. Antenatally, there was polyhydramnios. This was a preterm baby with birth weight of 1.9 kilos. History suggestive of polyuria, documented as 6 ml per kg per hour, and she was dehydrated. The child was hyponatremic, hypokalemic, hypochloremic, and had a high urinary chloride. The serum creatinine was normal. The bicarbonate was 34, indicating a metabolic alkalosis. The calcium, phosphorus, and magnesium levels were normal. The plasma renin activity was high, and the blood pressure was low. This was confirmed to be a Bartter syndrome type 3 by next generation sequencing, and the child was managed for Bartter syndrome with indomethacin and potassium chloride supplements. Our last case is a 1-year-old boy referred due to being sick looking with acidotic breathing, found to have metabolic acidosis with a creatinine of 3.8, and review of the history indicated there was antenatal detected bilateral hydronephrosis with oligohydramnios as well, but the parents had not been counseled regarding postnatal evaluation of hydronephrosis. And this case, when an MCU was performed, we found that it was a PUV. The child was catheterized even before the MCU, and the creatinine fell rapidly within 24 hours from 3.8 to 0.8. Later, he underwent a fulguration and was found to have features of a secondary neurogenic bladder, a valve bladder syndrome. So from all these cases, we can see that the pathogenesis of severe complications of CKD is because of various factors. These also include VH, IGF-1 axis disturbances leading to growth failure. The anemia and the hypertension are going to lead to a concentric left ventricular hypertrophy. And the CKD mineral bone disorder is mediated by various things such as a low GFR leading to hyperphosphatemia and increase in the FGF23 and the parathormone levels, which result in bony deformities, fractures, and also ectopic calcifications. Various uremic solutes such as beta-2 microglobulin, guanidosuccinic acid, P-cresol sulfate, indican, dimethylamine, myoinositol, pseudouridine, oxalate, and glyoxal also contribute to the growth retardation, anorexia, vomiting, and other manifestations of CKD. And so it is important that we control the proteinuria, hypertension, and metabolic derangements, as these will retard the progression to end-stage kidney disease. So we should control the proteinuria by giving AC inhibitors or ARBs, hypertension, metabolic acidosis, because metabolic acidosis, what happens is, when there is metabolic acidosis, there is ammonogenesis in response to the acidosis, and this contributes to complement activation. And this is characterized by a pro-inflammatory state in the tubules, and that leads to progression of the chronic kidney disease. Similarly, attention should be paid to hyperphosphatemia management by providing appropriate phosphorus chelation, because when there is hyperphosphatemia, there is FGF23 increase, which amplifies the myofibroblast activation, and this will contribute to renal scarring. Anemia is also going to lead to HIF-mediated fibrosis. Let us see the potential drugs of the future. This include sparsentan, which is an angiotensin II inhibitor, and this will prevent the binding of the angiotensin II to the AT1R receptors, and also it is a blocker of the endothelin-1. So this sparsentan acts by inhibiting the signaling pathways in both FSGS and IgA nephropathy in adults. It has been shown to be useful. It will reduce the activation of the renin-angiotensin-aldosterone pathway, and also act as an endothelin receptor antagonist. And this will lead to a renal protection. Similarly, another drug of the future could be dapagliflozin. Both the drugs are not yet licensed in children for clinical use, but this also has been originally used in diabetes. It is actually a SGL2 inhibitor, and it leads to glycosuria, but indirectly it is also going to lead to decrease in the albuminuria and prevent a pathological injury in the kidney, thereby providing renal protection. So the take-home messages from this talk are that the pathogenesis of CKD involves a complex interplay of congenital anomalies, genetic factors, and acquired conditions. And this leads to progressive kidney damage and reduced function. Children with low birth weight, prematurity, chronic disease, chronic medications such as analgesics, etc., single kidney, acute kidney injury survivors, etc., need follow-up for protecting their kidney health. Controlling the proteinuria, hypertension, metabolic acidosis, hyperphosphatemia, and anemia will retard the progression of CKD. Of these, the two most important ones would be proteinuria and hypertension. But yes, metabolic acidosis, hyperphosphatemia, and anemia management are very, very important. As I mentioned, metabolic acidosis leads to ammonogenesis in response to acidosis, and this contributes to complement activation. The hyperphosphatemia increases the FGF23 levels and amplifies the myofibroblast activation. And similarly, the hypoxia-inducible factor-mediated fibrosis that occurs in anemia also contributes to kidney disease. A high index of suspicion is required to identify CKD, especially when there are unexplained non-specific features. Thank you.
Thank you, Dr. Sriram, for your elaborate presentation with nice case discussion. You made a complex subject for us palatable. And now we'll go to the next speaker, Dr. Sunil Reddy. Please.
Yes, ma'am.
Kalavani, please share his CV template. So already Dr. Sriram has mentioned some modifiable factors to prevent CKD. So Dr. Sunil will discuss on those things. This is our pediatrician and pediatric nephrologist duty to prevent the progression of CKD. So Dr. Sunil Reddy is a pediatric nephrologist of Christian Medical College and Hospital, and his field of interest is renal just I just missed it. Okay, over to you, Dr. Sunil. Please go ahead.
Good evening, everybody. Today, my topic of discussion, are you able to see the slides?
Yeah, it's
Today, my topic of discussion is role of a pediatrician in prevention of CKD. As the old saying goes, prevention is always better than cure.
I'm not able to see your slides.
no, slide is showing.
Can you see the slides, ma'am?
Yeah, I'm able to see.
Rest of them?
Amrish,
I
are
can
you
also
able to
see
see
it.
the slides?
Yeah, we can see it.
Okay.
Okay. As I'll continue, ma'am, then.
Yeah, please.
Okay. As the old saying goes, prevention is better than cure. Keeping in line with it, pediatricians can play a very big role in prevention of CKD by identifying the population, whom to screen, when to screen, how to screen, in thereby identifying the cases of CKD and retardation of the progress of CKD. For us to do that, we should know the magnitude of global burden of CKD. So for that, we need certain numbers. So CKD affects up to around 10% of adult population, and the impact of the CKD is premature death. So, but in pediatric population, this systemic assessment and information is missing. So the most available current data is from the registries of kidney replacement therapies from the Western world, mainly European registry and the American registry. These are basically hospital-based data. So Hambert et al. In 2023, based on his population studies, suggested that there's a prevalence of around 1 to 10 per 1,000 children of CKD, which is very similar to childhood cancers or diabetes. This translates into end-stage renal disease with an incidence of 5 to 10 per million children, with a 30 times more mortality compared to a healthy aged matched population. So going to the Indian figures and what are the factors which play a role in this is, Jha et al. In their study, they concluded that the overall prevalence of impaired kidney function is roughly around 5%. And the prevalence in different age groups, between 5 to 9 age group, there was a prevalence of 5 to 6%. 10 to 14 was around 3.4%, and 15 to 19, the adolescent age group, was around 5 to 2%, 5.2%. So the factors which play a crucial role in this impaired kidney function was what they have identified as age, rural residence, social caste, which roughly translates into economic status of the family, educational status of the mother, religion, children with malnutrition, and residence in South India, which played an important role in impairment of kidney function. So this is the pictorial representation of their weighted prevalence of impaired kidney function in the entire country. As we can see that the southern states, two states have around 19.8 and 29.6. Probably one of the main reasons for this kind of figures is consanguinity is very high in these both states, and it is socially very acceptable in this part of the country. So to define what is CKD, the kidney damage for more than or equal to 3 months, defined by structural or functional abnormalities of the kidney, with or without decreased glomerular filtration rate, manifested by one or more of the following features: abnormalities in the composition of blood or urine, abnormalities in imaging tests, or abnormalities on any kidney biopsy, a GFR of less than 60 ml per minute per 1.73 meter square for more than or equal to 3 months, with or without above mentioned signs of kidney damage. So this is a staging according to KDIGO guidelines. This is a heat map, and according to the eGFR and albuminuria, there are totally 5 stages of kidney disease and 3 different ranges of albuminuria which they have categorized. And there are 4 different colors in this. One, we can see it's green, 2 is yellow, 3 is orange, and 4 is pinkish or red. The significance of this color-based thing is that the green, yellow, and the orange are the low risk and the intermediate risk, and the higher ones are the high risk and later stages of CKD. So the factors which are mainly involved in this CKD is low birth weight, like sir has explained already, prematurity, previous history of AKI, use of nephrotoxic drugs, reduced kidney size, genetic abnormalities, and a low nephron endowment. So this is a pictorial representation of EGA European registry with their annual report in 2019. So we can see that there are two concentric circles on the outer one, and the second one is the inner one. So the inner one represents the etiology of the kidney disease, and the outer circle represents the percentage of genetic reasons for that particular etiology. So in this pictorial representation, we can see that 40% of the CKD is because of congenital abnormalities of the kidney and urinary tract. And out of that, 28% of them had a genetic component to it. So across the CKD registries, both the Italian, Spain, Spanish, Japanese, and Korean. The main important thing is, if you can see the first parameter, it's SCACUT is the most common thing. It is ranging from anywhere between 40 to 60. So the epidemiology and the registry for the etiology of CKD, it is actually very different in pediatrics and in adult population. In children and young adults less than 25-year-old, CACUT, steroid-resistant nephrotic syndrome, chronic glomerulonephritis, and ciliopathies account for more than 70% of the cases, with 10 to 60% of the cases having monogenic causes. So Krishnamurthy et al. In 2022 published their data in Indian Journal of Pediatrics, enrolling 131 chronic kidney disease children. Out of them, the etiology which they have found is obstructive uropathy, chronic glomerular disease, reflux nephropathy, cystic renal disease, inherited tubulopathies, renal hypoplasia and dysplasia, neurogenic bladder, atypical HOS, renovascular causes, and other miscellaneous causes. So out of these, together, CACUT constituted around 54.2% of this study population. The same figures were roughly also achieved in St. John's Medical College, Bangalore, where they have published a paper. There also CACUT was somewhere around 60%. So the presenting symptoms in these 131 patients with CKD was hypertension, failure to thrive, anemia, urinary tract infection, bony deformities, incidentally detected edema, voiding dysfunction, antenatal anomalies, polyuria and nocturia, encephalopathy, hyperkalemia, and past history of AKI. So if you see the first and the last, so hypertension is around 82 patients had hypertension, which roughly is around 60% of them. So most of the children who go to their OPDs for any ailment, nobody checks hypertension. So to catch a CKD, this if we can figure out the hypertension in OPD, that's going to help us a lot. Similarly, nobody takes a history of AKI in a regular OPD. So if we can get the history of past AKI, in this study, almost 42% of them had a previous history of AKI. So if we can address the problem of previous history of AKI, probably there can be retardation of the progress of CKD in future, taking certain preventive measures. So to do that, we need to have a strategy. So in this strategy, the first step is to determine an individual or a population who is at risk. For them, we have to do a screening test, because we are going to anticipate that there is going to be a CKD in this. If there is no CKD, we can call them back regularly again and again and keep rescreening. If there is already a confirmed diagnosis of CKD, then we can stratify them according to their risks, then stage them accordingly, put them in the prognosis, prognosticate the parent, and also start the treatment. So who are the children who needs screening? Is any family history of renal disease, because renal disease has a genetic component to it. It can have autosomal dominant, autosomal recessive, or even sir has presented one X-linked dominant disease. Antenatally detected renal anomalies, neonatal acute renal failure, low birth weight babies, children with history of recurrent UTI with reflux. This one also, sir, has presented a case. History of nephritis and nephrotic syndrome, lower urinary tract obstruction, PUV, which this one also, sir, has shown as a case. Diabetes mellitus, autoimmune diseases like lupus nephritis or dermatomyositis, hypertension, or any long-term use of NSAIDs. These are the children who are at the risk of development of CKD. These have to be regularly followed up. So how to start and how to follow them up? So the cheapest investigation we have is always a history. So the history should always start from the antenatal period. So the antenatal period history should start from any maternal infections, like probably torch infection, cytomegalovirus, CMV infections. They can have an impact on the fetal kidney development. Did the mother have regular vaccination like rubella vaccine? Did she receive it in the past? And was there any history of oligohydramnios during pregnancy? And during birth, what was the weight of the baby? Low birth weight baby and IUGR babies have low nephron endowment and may have future CKD. After birth, was there any history of asphyxia during that time? Was the child admitted in ICU? Did the child receive any nephrotoxic drugs during that time? Postnatally, especially if there is a male child, when was the urine pass? What was the stream of urine? Was there any history of dribbling? Any other symptoms in an older age group? Was there any nocturnal enuresis? Was there any growth retardation? Was there any fatigue because of anemia? On examination, we can check for pallor or edema, anthropometry, any stunted growth or any malnutrition, blood investigation, simple urea, creatinine, sugars, HbA1c, because obesity and metabolic syndrome are on the rise. Lipid profile and electrolytes can throw a light towards CKD. Urine investigation, simple urine routine to check for proteinuria and hematuria. Ultrasound imaging, where we can see the size of the kidney, the echogenicity which is there in the kidney, the corticomedullary differentiation which is there, the visibility of the ureters, the bladder, the thickness of the bladder, any fenestrations in the bladder. Is there any obstructive pathology which we can see in the bladder, like keyhole sign, which can be seen? And if you happen to have previous family history of any kidney disease, which can be having a genetic component, we can always have a genetic testing. So based on this history examination, we can have a risk assessment, which is a traffic light system. The mild risk and the moderate risk, which needs to be followed up a little, maybe once in 6 months or 1 year. But a high risk needs a continuous and a regular follow-up and even a referral to a pediatric nephrologist. So the prevention strategies, so we can divide the entire population into primary prevention, a secondary prevention, and a tertiary prevention. So the primary prevention will always aim at elimination and reduction of exposure to factors that can cause renal disease. For example, reduction of antenatal exposure to infections like any fever with rash, toxoplasma, or rubella, or any drugs. If the mother is, for example, mother is hypertensive and she is receiving ACE inhibitors, there is a very good possibility for renal agenesis in the fetus. So any genetic counseling, if there was a prior history of any renal disease in the family or a previous childbirth which had a significant kidney disease, then they can be sent for genetic counseling for the next pregnancy. To have a clear, good antenatal ultrasound to look at the kidneys, their echogenicity, any cysts present in it, size of the kidneys, to look for oligohydramnios or any post-obstructive uropathy can also be seen in this antenatal ultrasounds. So postnatal follow-up, if there is any obstructive uropathy, look at the stream, then go for MCU, probably go ahead with the DMSA also later. And in some older children, prevention of obesity and dyslipidemia, advising them on diet and regular protein checking in the urine along with hypertension checking. Early detection and management of this hypertension and diabetes also can be a part of this primary prevention. Previous history of any AKI, infections like malaria and dengue, they can have AKI, so these need to be kept under regular follow-up with checking for hypertension and proteinuria so that we can have an idea about what is their kidney health. Nephrotoxic drugs, if they have received in the past, like it can be NSAIDs, it can be antibiotics like aminoglycosides, or any contrast which has been given in the past, because contrast-induced nephropathy also can lead to kidney damage. The secondary prevention is, once we have identified and we know that there is a component of kidney disease, we have to stage them into 1 to 5, and appropriately we should take measures so that this progression is slowed down. For example, if there is proteinuria, we're going to start on ACE inhibitors to reduce the proteinuria. If there is anemia, we are going to top up with iron supplements and erythropoietin if needed, and vitamin B12 and folic acid also. If there is any metabolic acidosis, we can go ahead and start off on bicarbonate supplements. Calcium, phosphorus, and PTH can be checked along with vitamin D, and calcium supplements can be given, phosphate binders can be added, and to reduce the impact of secondary hyperparathyroidism, active vitamin D also can be started. Vaccination plays an important role because in future, when these children may land up in kidney replacement therapy or for a transplant, they have to be ready by then. And there are a list of vaccinations which need to be given, which have to be planned, and this is going to take time. So roughly the child should be totally vaccinated before 28 days before the transplant is going to happen. So it should be finished by that time. So it needs a planned sequence. So, and if there is a necessity for kidney replacement therapy, like for example in stage 5, then there should be a referral to immediately to a nephrologist. So tertiary prevention will be like reduction in delay of long-term complications, impairments, or disabilities in an established disease which is going to require kidney replacement therapy. So the kidney disease children, these are the parameters which need to be monitored by a pediatrician. Looking for anemia. So simple complete blood count with the peripheral smear to look for microcytic anemia, which can indicate iron deficiency. If it is a macrocytic, it can be a vitamin B12 or a folic acid deficiency. Iron studies should be done on them, and with serum iron, a TSAT, and depending upon that, we will be deciding on oral iron or parenteral iron, or even addition of erythropoietin. Calcium, phosphorus, vitamin D, and PTH to look for mineral bone disease. Bicarbonate to look for metabolic acidosis. Regular hypertension, there can be undetected hypertension. So an ABPM also these days, quite a lot of children are under ABPM, and we could detect a lot of undetected hypertension in them. And children who are already diagnosed with hypertension and are already on drugs for end organ damage, we should be doing an echo to look for left ventricular hypertrophy or left ventricular mass index. In children who have electrolyte abnormalities, mainly hyperkalemia and hyperphosphatemia, their diet should have a detailed diet chart should be made in accordance with the pediatrician and the dietitian to decrease the level of potassium and phosphorus they are going to have in their diet. A vaccination plan should be made, and prognosticate the parents about the referral, a need for kidney replacement therapy, and a future transplant. So this is the list of vaccination which we are going to do in a chronic kidney disease child, so that they are ready before the entire transplant plan comes in. So an MR vaccine for 1 dose, DTaP vaccine 1 dose, conjugate typhoid vaccine 1 dose, Hepatitis A vaccine, 2 doses 4 weeks apart. Hepatitis B vaccine, 2 doses 4 weeks apart. Quadrivalent HPV vaccine, 2 doses 4 weeks apart. Pneumococcal vaccine PCV 13 followed by PPSV 23 8 weeks apart. Hemophilus influenza vaccine 2 doses 8 weeks apart. Influenza vaccine 2 doses 8 weeks apart. Varicella vaccine 2 doses 4 weeks apart, and quadrivalent meningococcal vaccine 2 doses 4 weeks apart. And now I'm going to present some case scenarios which we had seen in our OPD. This is a 12-year-old boy who had gross hematuria following a URI. On history, he had previous 2 episodes which were similar in presentation, and it resolved on its own. So because it was the 3rd time they had come to our OPD, and examination wise, his vitals, blood pressure and anthropometry was normal. Systems were normal, more or less. And he was never investigated prior. So we considered differentials of basement membrane disease, hypercalciuria, and we did certain investigations. Creatinine was 0.6, but his urine examination showed microscopic hematuria, which was persisting. At this point of time, he did not have any gross hematuria. He had subnephrotic range proteinuria, and ultrasound was normal. So we did eye examination because Alport syndrome was on the differential diagnosis list, and we found anterior lenticonus, and hearing, which we did showed hearing loss. So as a part of this entire thing, we did the screening on the parents also, and we found that the mother also has proteinuria. So then later genetics were sent, and both of them turned out to be Alport's syndrome. Case scenario 2. This is a 14-year-old boy, apparently normal, presented to pediatric OPT with recurrent abdominal pain. No significant past history. The only history which we got after he was referred to our OPD was family history with grandfather. He was on dialysis for a brief period of time, around 1 to 2 months, and he expired. And this was around 10 years back, and they didn't know what was the cause. So on examination, his vitals and anthropometry were normal. He had stage 1 hypertension, but when he had actually gone to the local pediatrician, he has noted that this is high BP, but due to lack of awareness, or it slipped out of his vision. So he did not label it as hypertension. Then when we examined the system bilaterally, there was a palatable mass, and his creatinine was 2.3. Ultrasound showed bilateral bulky kidneys with multiple cysts involving the entire kidney. So we screened the father. The father also had a similar picture. His creatinine was 4 already. So we sent a genetics, and it turned out to be autosomal polycystic kidney disease. Case scenario 3. This was a 3-year-old girl child who went to an orthopedician for bowing of legs, and she was treated as vitamin D deficiency. And since it did not resolve, and she was labeled as refractory rickets, and she had been referred to us. There was history of consanguinity in the parent. On examination, she had stunted growth and she had polydactyly. On examination of thorax was very abnormal looking shape. It was bell shaped with rachitic rosary. So the rest of the systems were normal. She had subnephrotic proteinuria, and the creatinine was elevated. The same creatinine even the orthopedician had seen, but he did not realize that it is elevated for this age group. So this is lack of awareness. So when we sent genetics, this turned out to be Joanne syndrome, which is autosomal recessive. This is a young couple, so we had sent the parent for genetic counseling. So the message is that there are a large number of clinico-pathological conditions which can produce renal damage in children. Anticipation is the most important thing. So after anticipation, you recognize, you putting in place of the strategy, then you institute the preventive measure so that you can decrease the morbidity, mortality, and economic burden of the disease. And in a country like India, where dialysis and transplantation care is not within the reach of many children, the steps should be taken to prevent the onset and the progression of CKD in children. Thank you.
Thank you, Dr. Sunil, for your nice presentation. So now is the time for question answer session. Okay, in the chat, in the question answer box, there is one question. I think it's to Dr. Sriram. Indication and contraindication of enalapril in CKD.
So enalapril is recommended in CKD for its antiproteinuric and antihypertensive effects. It is supposed to be used in CKD. It's the antihypertensive of choice. From stage 4 onwards, we are a bit cautious to monitor the potassium levels because hyperkalemia would be more likely from stage 4 onwards. Otherwise, it's mainly when there is hyperkalemia, then we have to avoid it. The usual contraindications of enalapril, like bilateral renal artery stenosis, pregnancy, these are the usual, and hyperkalemia. These are the usual contraindications. Enalapril is recommended for hypertension and antiproteinuric effects in CKD patients. And in CKD 5, if they are on dialysis, you can use enalapril for its antirenin activity.
Okay, thank you. And there is no more question. One thing I just want to ask you, Dr. Sriram. So you have mentioned about this ACE inhibitor and ARB and also the dapagliflozin. So can you please tell us the role of SGLT2, the newer drug? So any role in prevention, the progression of CKD in children? We know in adult they are doing, they are using it. In some trial are also ongoing. But is there any role
Mainly
in
for
pediatric CKD?
it's not approved for clinical purposes. Research
Yeah.
is going on. Diabetic nephropathy in adults, it is approved. It's only for research purposes in children right now. It will come in the future, I hope.
No trial is ongoing on this in children. I think in an adolescent age, there is one trial is.
Yeah. That's what, for research purpose, it's going on.
Yeah.
Not yet approved for clinical usage.
Some more question is there. Please explain the mechanism of decreasing proteinuria with enalapril. So you have mentioned it already in your lecture.
I think I've mentioned in a lot of detail, I think.
Very nicely you have mentioned.
So the angiotensin 2, it acts on the AT1 receptors. And when it acts there, then you get all this proteinuria through the pro-inflammatory action, vasoconstriction, etc. TGF beta increases. So when you give AC inhibitors, ultimately proteinuria will come down because of its anti-inflammatory action and anti-hypertensive action. It will come down.
It's okay. Another question is from Dr. Sangeeta. Till stage 3-1, we can give enalapril. Enalapril is our question. We can.
Up to 3B, there will be no issue, I think. You just have to carefully monitor whether there is a extreme rise in the creatinine. Up to 20 to 25% rise in the baseline creatinine is expected with enalapril. If it rises excessively or if there is a chance of acute kidney injury and all, then you should be careful. If it rises more than 30% and all, you can't accept it. So then you will have to either withhold it or reduce the dosage. Up to stage 3B, it is the drug of choice for hypertension and antiproteinuric actions. From stage 4 onwards, as I mentioned, we have to be careful. Similarly, we should not use enalapril during hypovolemic states because its nephrotoxic potential will be enhanced.
Okay, one more question. Approach for a pediatric atypical HOS in Indian scenario. Trial for eculizumab in India. Not. I think it's not related to our topics today. So, there is some comment in the chat box from Dr. Nahla Alam from Sub-Saharan Africa. She has told that in their region, the CKD glomerulonephritis, especially mainly the infectious glomerulonephritis. They have one paper on African Journal of Pediatric Nephrology. And people are very interested about atypical HUS. Some more comments are there. Approach for pediatric atypical HUS after plasma exchange cycle. Any trials for enrollment for free plasma exchange or eculizumab in India?
I think few centers are using eculizumab, but free trials, I don't think so.
Oh, I think Aditi madam only will be able to tell us this now.
If
Yeah.
she's here with us. She was there, but now.
There are few centers who are using eculizumab in India, but it has been imported. FDA, like, are we getting it right away? Like, we are unsure.
There is no free plasma
But
exchange.
there is no free plasma exchange at all. There's such
They
trials.
do anti-factor H antibody and that this thing for free of cost. That they do. But this eculizumab, I'm not very sure if madam has any trial with her. But if at all somebody has, it should she only will have the perfect information. And the approach also, madam has there is one paper which is written by them. The approach is given clearly in that in a flow chart.
If eculizumab is not available, you can still go ahead doing a plasma exchange.
Plasma exchange.
So one more question is there. Any guideline for pediatric AV fistula in India?
Is it related to today's talk?
Not, sir. If you're interested, you can take up that question.
Really, but they are very interested to know all this. They got the
So-
chance.
So AV fistula, we would start counseling patients for CKD stage 4 for AV fistula. We would start counseling them. In stage 5, we would create it. But in certain situations like primary hyperoxaluria type 1, from stage 4 onwards itself, we start kidney replacement therapy. So in our experience, we create AV fistula and many children are doing very well. We do thrice a week as recommended. If it is primary hyperoxaluria, it would be more intensified.
I think once we diagnose CKD itself, we make sure that the veins are not punctured frequently. That is the first step we take, preserving the veins. And then we go ahead doing as Sriram sir highlighted, like we counsel them, and then because fistula is going to take minimum 8 to 12 weeks for the maturity.
We
Otherwise,
follow the rule of 6. We
Follow-
follow the rule of 6s.
rule of
So,
6,
it should
yeah.
be, so 6 weeks after the fistula has been created, the fistula should be 6 centimeters in length,
6 depth.
6 millimeter depth. The 600 ml per minute should be the
Adequate.
flow rate.
Yeah.
Flow rate. And so after that, most of our patients on fistula are having brachiocephalic. Radiocephalic is more for older children. The younger ones, brachiocephalic is more successful. But then you should always attempt to create from distal to proximal.
Okay. So no more question here.
So can we move on to polling sessions if we don't have any further questions? I think Dr. Sunil did a great talk, and Sriram sir, it goes without saying, he did a very great illustration of pathogenesis of CKD. Amrish, do you have any comments to say?
Yeah, no, thank you to both the speakers, Dr. Reddy and Dr. Sriram. Those were excellent talks, and Dr. Sriram's talk having covered all the interesting cases, and Dr. Reddy's talk covering what pediatricians need to look for. I think those are very, very educational. So thank you, thanks to both of you.
Thank you, sir.
Thank
Thank
you.
you, Sriram sir. Thank you, Sunil. I think if you're interested, you can stay back for the polling session. Can we go to the polling session? I'll just do the instruction for the polling session. Are my slides visible now?
Yes, ma'am.
Yeah. So totally we'll have 10 questions in the polling session, and the polling session are totally 6. So we are starting the polling session from today, and it will be there till April 30th. So like we request all the participants who are going to get enrolled for the polling session to enter their email ID, because that is the only source of contact for us. And each session is going to have 10 questions, and it is mandatory to answer all the questions to proceed with the submission process. And the total duration is going to be only for 5 minutes for the 10 question. It is because we don't want anyone to Google search and enter the answers, because it is all online. And we will have 4 star questions in each session, and star questions are considered only in case of tie. And the cumulative score for all 6 polling sessions is going to be taken into consideration for the winners. So like we request all the participants to log in on time using a bigger screen for ease of viewing the questions. And for better view, you can use the landscape mode. So you can use the same link, the polling questions will be projected, and you can actually click and make sure you're answering all the questions. Only then you can process for submission. Is the IT team ready for the polling session? Thank you. Good luck.
Yes, ma'am. Can we start, ma'am?
Yeah, can we start? Yeah. The timer can be switched on. Can you project the questions and stop sharing?
Once more.
So the polling session starts now. So the next 5 minutes is for the poll. Only trainees are allowed to participate for the polls. Is the timer visible on the screen for the participants? Two more minutes. We are done with the polls. Can you stop sharing the questions? Amrish, can you conclude?
Yep. So again, thank you, everybody. Thank you, Dr. Zubaida, for your moderation and keeping us on track. And thanks again to both the speakers, Dr. Reddy and Dr. Sriram. We look forward to the next session, which is going to be Wednesday. Thank you, everybody.
Thank you, sir.
Thank you, sir.
Thank you, ma'am.
Thank you.
Thank you.
Thank you. Bye.